Well, I'm not seeing any. Good afternoon, everyone, and welcome to this Friday's briefing from Independent Sage. The more observant of you will realize that I'm not Alice Roberts, neither any of the fantastic chairs that we've had along the way. But nevertheless, we've got a star cast today, and we're going to be focusing on that critical issue of climate change. We've all witnessed the various politics and campaigning associated with COP26. And of course, there are immense health implications of that, particularly around pandemics, current and future pandemic planning. So we will come to that in a little while. In the meantime, let me please introduce Professor Colin Davis, who is a experimental psychologist from the University of Bristol, and has focused recently on how to demonstrate and visualize the COVID data. He's widely renowned particularly on the Twitter sphere. So we're very pleased for Colin to join us and to present our COVID data for this week. Over to you, Colin.
Well, thank you, Dina. It's very nice to be here, particularly in a week when you are focusing on climate change, because, of course, COVID is a hugely important global issue, but still not in the same league as climate change. So I'm really glad that people are thinking about that and thinking about the relationship between these two crises. So what I'm going to do this week is talk a little bit about the boosters, some recent evidence on efficacy and how the rollout program is going. Then I'll talk a little bit about the situation in the UK with cases, how they've been influenced by some recent events. And then we'll talk a little bit about the international comparison. So let me share my screen. I can show you some slides, hopefully. So can you see my slides okay now? Hopefully you can see this graph, which shows a report just published by the UK Health Security Agency looking at booster efficacy. So this is some very good news. We know that one of the things that's really important for encouraging people to take the vaccine is knowing just how effective it is. And what these data show is that if you go from being double vaccinated to having the booster, then the efficacy against symptomatic infection goes from between 40 and 60% up to close to 100%. So that's really good news. So I'd encourage everyone to get their booster as soon as they are eligible. And the program there is going quite well. It got off to a little bit of a slow start, but we're now moving close to 400,000 booster shots per day. So the rate has increased, and it seems to be on an upward trend. And we have now given boosters to over 3/4 of the over 70s, about half of people in their late 60s, and it's gradually moving through the population. Thanks, by the way, to Bob Hawkins for this graph and lots of the graphs I'll be presenting today. Now, of course, the booster rollout is not the only vaccination rollout that we're working on at the moment. Another one is focused on teenagers. And unfortunately, that one is not going quite so smoothly. So it's been going for about the same amount of time, but at a much slower rate. We've only vaccinated fewer than half of teenagers in England and only about 1/4 in Northern Ireland. So I think we really need to try and pick up the pace there. And before I move on from vaccines, let me show you one more graphic looking at the distribution of vaccines across the world. And I think this is really a rather shameful graph. It plots the number of doses administered against the national income. And what you can see here is that in rich countries like the UK, we're doing pretty well with our vaccine rollout. But by and large, in poorer countries, many people have not had a single dose yet. So we're getting our third dose now, and people in poorer countries still haven't had a single dose. And clearly, this is an issue of global justice. These are countries who are least equipped to be able to respond to the crisis. And I'm not suggesting that we should be transferring doses from the UK to elsewhere. I think really the issue is about this whole notion of vaccine scarcity, which is really a manufactured problem designed to produce large profits. And I think there's a direct parallel between this issue and climate change, subject to today's session. And the failure of governments to challenge corporate interests here, I think, doesn't bode well for the fight against climate change. And perhaps people will return to that issue later on today. Okay, so let's have a look at what's been happening with cases in the UK. Over the last 6 months, we've gone from having relatively few cases in May up to a peak in mid-July when we had the Euros and Freedom Day. And then in the first part of summer, cases dropped down a bit, but we didn't manage to get cases right down. And they started to drift back up in the latter part of summer. But what I'll particularly focus on today is this kind of up, down, up pattern that we've seen in the last couple of months. Because I think it's good to try to understand the dynamics of what's going on here. These are big effects. We'd like to know how to stop steep rises in cases like this, and also what we can do to bring about steep drops in cases like this one that we saw at the end of October. I think it's helpful to look at how this breaks down by age group. And clearly the age group that has dominated cases and where you can see this up, down, up pattern most clearly is in 10 to 14-year-olds, so early secondary school students. There is a similar trend in 5 to 9-year-olds and 15 to 19-year-olds, but it's a much smaller effect in comparison. And interestingly, we don't see any sign of that trend in young adults. They showed a slight dip at the start of September, but have been pretty flat since then. So we can ask, well, how did we manage to bring infection rates down so rapidly? And some people have suggested that maybe it was because this age group of 10 to 14-year-olds has now attained herd immunity, but I think that seems unlikely, particularly given that we are now seeing further growth in cases in this group. So there may be multiple things going on, of course, but I want to suggest that the critical factor was a non-pharmaceutical intervention that we call half-term, because this is a kind of a circuit breaker which literally breaks the chains of transmission. Because during term time, children who, remember, are mostly unvaccinated are spending their days in crowded, poorly ventilated spaces. And during half term, they have the opportunity to get out of that environment. And that allowed rates to fall very rapidly in school-aged children. And it also explains why we don't see that trend in young adults, who, of course, don't go to school and don't have a half-term break. So let's add the other adult age groups to this graph to see what they look like. And what you can see there is that, by contrast with children, the absolute rates in these groups are much lower. And because of the scale, the trend might look relatively flat. But if we zoom in on just those groups, then we can see that actually they do show a similar pattern, an increase during the school term, a flattening rather than a decline during the half-term break, followed by a decline in the following week. And that's particularly apparent for the age group that includes parents of school-aged children. And that group we can see has now returned to growth. For the older age groups, things seem to be relatively flat over the last few days, which is better than growth, I suppose. But we're not yet seeing a really obvious effect of the boosters on cases. Hopefully that will become apparent over the next month or so. Now, the data we've been looking at so far are from people who take tests because they are symptomatic or as part of their school routine. So you may well ask how representative these case data are. And a good way to address that is to do random community sampling, which is what the REACT study does. And the latest round of this study has just been reported. It covers the period from 19th of October to 5th of November. It's based on a sample of about 100,000 people, so a good-sized sample. And what the data show here is a very large increase from the previous round. So prevalence has roughly doubled. So prevalence is now more or less the same as at the January peak, corresponding to roughly 1 in 64 of the population testing positive. Now, of course, the rates of hospitalization and deaths are much lower than they were in January, and that demonstrates the power of the vaccines. But I think it's not ideal, all the same, that we have such high rates of transmission in the community. In fact, if you look at this graph a little bit closer, what you can see is that prevalence has doubled 4 times since June. And if we were to experience a further doubling now, then I think that would put tremendous pressure on our health system. We can also break down prevalence by age, and what that shows is much the same thing as we saw in the case data. So extremely high rates amongst school-age children, roughly 1 in 20 in the sample testing positive. One difference is that the rates in 5 to 9-year-olds are almost as high as in teenagers, which maybe suggests that the public health test data might be underestimating the true infection rate in primary school-age children. And beyond that, we can see increases across the board from the last period. And the biggest increases in children are in the 35 to 54-year-old bracket. So that is parental ages. And in fact, we can break down prevalence into households with no children versus households with children. And that shows us that prevalence is higher in the households with children, and the biggest increase in the last round has been in that group. And I suspect that everyone listening is aware of their own sources of anecdotal data of children bringing COVID home and infecting double vaccinated parents. Now, interestingly, one consequence of this mode of transmission is that it seems to have shifted the pattern that we saw earlier in the pandemic, where prevalence rates previously were much higher amongst the most deprived. Now, prevalence doesn't really vary very much across levels of deprivation. And that's what I think you might expect when it's hard for anyone with children to avoid exposure to COVID. And we can also break down prevalence by region, and that shows that the region with the biggest increase over the latest round of testing is the Southwest. It's gone from having the lowest rate to the highest rate. And I believe we're still waiting for the UK Health Security Agency to update us on its investigation into the lab that gave out incorrect test results. And I know that there are a lot of us living in the Southwest who are keen to see a proper investigation of that scandal. Now, another source of random sample data that comes out every week is the Ons Infection Survey. That was just released about an hour ago. And that shows a similar pattern with the highest rates in secondary school children, but now primary school children catching up. And we can see that same kind of up-down pattern. And there's a slight lag in these data, so these haven't started going up yet. You can clearly see that the decline has flattened there. Now, I just want to return briefly to this slide to consider a possible objection that some might have, which is that if this steep decline that we've seen really is a half-term effect, then why does it appear to begin just before the start of half-term? And it's worth noting that, in fact, half-term starts earlier in some parts of England and at many independent schools. But something else that might be relevant is that when rates got as high as they did, and up to 10% of children testing positive each week in some places, then inevitably schools were forced to bring in various mitigations. Some schools closed, and many children were absent from school. So at the end of the last term, there were 200,000 children a day absent with COVID or suspected COVID. And that self-isolation will, of course, have contributed to breaking the chain of transmission. But it is a heavy-handed measure because what we're seeing here in this graph reflects millions of days of lost learning. And a report published last month compared children's reading and math skills this year with previous year's cohorts to provide a measure of that lost learning. And what we see in this chart is a measure of lost learning in reading skills amongst primary school children. And you can see that children have lost months of learning, and the higher the levels of absence at a school, the more learning that was lost. And the effect is even larger for mathematics. And where there are high levels of absence, the children are almost 5 months behind where you'd expect them to be. So I think that's another reason why it's really not a great idea to allow these high levels of transmission within schools. Now, the problem of children missing school is by no means unique to the UK. But one thing that is noteworthy in this report that was commissioned by the Department for Education is that we are spending much less per pupil on education catch-up than comparable countries like the United States and the Netherlands. So that really isn't consistent with the messaging that we hear from the government about how their schools policy is driven by their concern for optimizing educational outcomes among children. Now, in addition to the educational outcomes, I think there's good reason to be very cautious about allowing high levels of transmission within schools because of concerns about health outcomes among children. I don't have time to say more about that today, but I'm sure that Christina will cover the next ONS long COVID survey when it comes out in a couple of weeks' time. But beyond that, there are health implications for the adults who are working in those schools and for the parents and grandparents of those children. And those implications include hospitalization and mortality. So let's have a look at the latest data on those outcomes. This is what daily COVID admissions in the UK have looked like over the last 6 months or so. And to a first approximation, you see that what's happened is that admissions grew from a very small level in May up to around 900 admissions a day in August. And if you look at what's happened since October, then, interestingly, you can see the same kind of up, down, up pattern in the last month and a half or so. So it's the same as the pattern we see in cases, but shifted by a week or two, which shouldn't be a surprise because although we have reduced the hospitalization rate, we never broke the link between cases and hospitalization. The more cases there are, the more hospitalizations we have. And the consequence of having around 900 patients admitted a day for the last few months is that there's been a continuous increase in the total number of COVID patients in UK hospitals. The level of increase hasn't been as steep since August, but if you look at a kind of a general trend, you can see that it's been an upward trend over time. It still looks like it's going up. And many of those patients are in mechanically ventilated beds. The prognosis for them, of course, is not so good. That brings us on to deaths. We are in a much better position than we were in January because of the vaccines. We had about 200 deaths reported yesterday compared with over 1,000 throughout January of this year. But what effectively we've done is we've spread the deaths out because we've had a high level of deaths for months now. So over 10,000 people have died since children went back to school. So I'm not convinced that that is a good outcome, given that we do have access to these very effective vaccines. Now, when you're talking about what would be a good outcome, we have to recognize we're dealing with a very challenging situation and an evolving virus, but it's interesting to consider international comparisons. Now, if you look at countries of Eastern Europe, then you might say, well, the UK is doing pretty well. They are having a very tough time in Eastern Europe at the moment, which does reflect the relatively low levels of vaccination that they have in those countries. So probably a better comparison for us, countries of Western Europe. And there you can see that whereas the UK has been doing much worse than other countries, now Germany is catching up, in fact, slightly overtaken us. Although there are other countries of Western Europe where things are going a bit better, like France and Spain in particular. So we might ask, well, what's the difference between the UK and Germany on the one hand and countries like France and Spain on the other? And that probably has something to do with pharmaceutical interventions. So UK and Germany have vaccinated about 2/3 of their population. You might think, well, I thought it was more than that. Well, the reason that it's a bit lower is because we haven't been doing so well with vaccinating teenagers. And by comparison, in countries like Spain, Italy, they're doing much better. So Spain has now vaccinated 80% of the population. They've done very well with their rollout of vaccinations to children. But it's probably not just pharmaceutical measures. Non-pharmaceutical interventions are probably also important. So in Spain, they decided that they were going to retain masks in schools at the start of the year, and they have had a much lower level of infections amongst children. So to summarize then, we can see that the boosters are working really well, and the rollout of boosters is speeding up. It's going quite well. But our vaccination program is not going so well for teenagers in this country or more generally globally. We have very high levels of prevalence at the moment. We can see that both in the case data and in random sampling. And that seems to be linked to the return to school and then the half-term break. The rate of admissions remains high and has been for a long time. So the total number of patients in hospitals is increasing. That's something that's happening not just in the UK. Many countries are showing increases. It is going to be a difficult winter, probably. COVID is not over. But what we can see is that both pharmaceutical and non-pharmaceutical interventions do make a difference. And hopefully we can learn from the example of other countries that are doing a bit better than us. So I'll leave it there now. And I think I'm passing over now to Anthony, who I think is going to tell us a bit about climate change.
Thanks very much, Colin. That's some fascinating data there. We're talking about climate change because it is an existential threat to all of us. It affects every region of the world right now. It links with our risk of pandemics. If you look at SARS, MERS, HIV, Zika, COVID, they all come from viruses jumping from animals to man. And these virus spillover effects are linked to the changes that cause climate change, like deforestation, degradation of tropical forests, poor animal husbandry, and then, of course, wildlife markets. But COVID has shown us the limitations of our global, national, government, public health systems. And we have to learn lessons from our failures because we only have 10 years to keep below 1.5 degrees of heating. Time's running out. So I've got two guests. I'm going to ask Dr. Marina Romanello first. She was lead author on the latest Lancet Countdown for Climate and Health Action Report that we released just before COP26. Marina, perhaps you could explain to our viewers why we are at code red for a healthy future.
Thank you, Anthony. I hope you can hear me well, and thank you for that introduction. Indeed, we're in a code red for a healthy future, and that's what our latest report has found. And I'm going to talk to you a bit about the threats that climate change poses on human health and why it's an opportunity for action to improve health for everyone. But first, I wanted to talk to you a bit about kind of what is climate change and where we're at now. There's no doubt today, we're absolutely certain that climate change is man-made, that we have anthropogenic contributions to climate change. And as you can see here, the concentration of carbon dioxide in the atmosphere has been continuously going up since the 60s. And we know that this is what's driving global warming and anthropogenic climate change today. But we do have negotiation and international negotiations going on, which, as you can see, have been fairly inefficient in doing anything about this, with emissions still going up. And you can see here where the climate pact that was just signed in Glasgow comes in, that we're hoping will manage to tilt the balance that we have not yet managed to tilt. And a very kind of simple diagram produced by the Climate Action Tracker, which is a great initiative, showing where we need to be at for the 1.5 goal of the Paris Agreement that is considered relatively safe. And I say relatively because no warming is safe at this stage. We're currently at 1.2 degrees of warming, and current policies and actions would take us to a 2.7 degree world, with current pledges and targets taking us only to a 2.1 degree world. So we're really far away from achieving what we have all signed up to do in the Paris Agreement, and what will be relatively safe for our health and our planet. And when we talk about climate change, it's obviously not about polar bears, not about 2100. It's about us today, our health, and the health of our children. And in this very complex diagram that I do not intend you to go into any detail on, all I want to show you is that climate change, through its alterations on the environment, is starting to undermine all of the systems that sustain our good health, the natural environment, the social environment that sustains our health and well-being. And it's starting through very complex pathways, as you can see here, an interconnected pathways, to really affect our physical, our mental health, thus shifting the transmission of infectious diseases and putting us at increased risk of emerging infectious diseases and pandemics. And importantly, all of the impacts of climate change on our social systems and eventually on our health is obviously mediated by social factors. And this is really crucial, particularly when we talk about how this pertains to COVID, because climate change really underpins a huge inequality and exposes, as much as COVID has done, the inequities that govern our global actions. What you can see here in this top graph is countries whose size has been distorted to reflect their contributions to accumulations of greenhouse gases in the atmosphere, therefore to climate change. And what you can see in this bottom map is mortality per million population in countries with their sizes as well distorted according to mortality per population. And as you can clearly see here, it is the countries that contributed the most to the global climate crisis that are less impacted or enjoy better health and better well-being, and those that have contributed the less, the ones that have the biggest burden of disease. And this is really what underpins the global inequities. And one thing worth taking into account is that this is a positive feedback loop, with the most disadvantaged communities, the most disadvantaged people being most exposed to the climate hazards, being most susceptible to the damages, and having least capacity to recover from those damages, which puts them in an increasingly disadvantaged position. So this is really, climate change underpins a global problem of inequities. And at the Lancet Countdown, we produce evidence on climate change and how this affects our health and how our response could be good to our health. And the first thing that obviously comes to mind when we talk about climate change is increase of heat and increased intensity and frequency of heat waves. And as you can see here in this graph on the right, global exposure to heat waves of people over 65 years of age that are particularly vulnerable to the worst health effects of heat waves, of the lethal effects of heat waves. Their exposure has been increasing all around the world, particularly since the 2010s. And we do have today a good level of science that allows us to attribute these heat waves to climate change. As you can see in the top note here, we today know that the heat wave that reached about 50 degrees of temperature in Canada, in the US this year, would have been virtually impossible without human-caused climate change. So we do know that we're generating this, and we're putting people, particularly vulnerable people, increasingly at risk. And with increased temperatures, we're also starting to affect our capacity to produce food and crops. We track at the Lancet Countdown the crop yield potential for the major staple crops. And as you can see here, due to rising temperatures, the maximum potential is going down for major staple crops that we're tracking. But it's also worth noting that climate change is starting to affect rainfall patterns, and the land area affected by extremes of drought is also increasing. We have more and more land area affected by extreme drought. And again, detection and attribution studies have allowed us to pin down climate change as a major contributor to drought events that have happened in countries that are really affected already by food insecurity, water insecurity around the world. And extreme weather events also come with climate change. We're seeing increased environmental suitability for wildfires with dry climate and higher temperature also come increased risk of wildfires. And 72% of the countries around the world have seen an increase in human exposure to wildfires since the beginning of the 2000s. And once again, we saw what happened in Greece this year. We saw the wildfires of Australia, and we do have detection attribution studies that now let us quantify the contribution of climate change to these disasters. And we're also seeing change in the environmental suitability for infectious disease transmission. We're seeing increased weather events, and we're starting to see multi-hit scenarios where climate change is really starting to undermine all of the foundations of our good health and leading to huge burdens of disease. And because of that, it's particularly important that health systems around the world start adapting and increasing their resilience to be able to cope with health emergencies as those brought by climate change, as the ones brought by COVID. And another thing that we're seeing with concern is that the response and the adaptation of health systems is really not being robust enough, with only 75% of countries around the world reporting medium to high level of implementation of national health emergency frameworks. And with particular big inequalities, with low and medium human development index countries having much less implementation than very high human development index countries, further contributing to those inequities. But one thing, and I'm just going to close with this, that is very important to note, is that when we talk about climate action and transitioning to low carbon economies, we're basically just requesting very sensible public health interventions that could benefit the health of everyone. We're requesting shifting away from air polluting fossil fuel burning. We're requesting that we reduce our excessive consumption of red meat and transition towards more plant-based, healthier, low-carbon diets, and that we increase our active travel and not move around so much in fossil fuel-based modes of transportation. That obviously all of that makes cities that are healthier, more livable, and improves our cardiovascular and overall health. And we have done this study earlier this year where we quantified the number of deaths that could be saved if we really went through prioritization of health in all climate policies, and they rise to the millions in only 9 countries that we studied. So it's a really strong case for climate action to protect everyone's health. I'm going to close with that and pass on to you again.
Marina, thank you very much indeed. That was brilliant. And if anyone wants to learn more, because this was a very long report, you can just go onto the Lancet website and download it absolutely for free. So I'll come back to you in a minute, Marina, but I want to move on to our second guest, David Pension, who is a professor of public health, but also former director of the NHS Sustainability Unit for many years. And my question, well, 2 questions to you, David, but we'll start with the first. What's the role that GPs and the NHS can play in moving towards a zero carbon world?
Well, thanks, Anthony. Well, the first question about the role of GPs or the role of the NHS is that we've now reached the stage in the climate crisis where no one can say this is someone else's responsibility. So there is something for everybody in this. And I guess the most important issue is that health professionals around the world tend to be the most trusted people. So silence is dangerous. So it's very important for health professionals to talk about climate change as a health issue, not as an environmental issue. So talk to their colleagues in terms of climate change as a health issue. And don't forget, nearly every health system in the world employs about 10% of the working population, and 10% of the GDP is wrapped up in the healthcare business. So the first thing to do is to make it a core dimension of quality in healthcare, delivering high quality care equitably in low carbon ways. And there are lots of ways we do that. And probably the most important way, Anthony, is through prevention. The most sustainable healthcare is healthcare we don't need to deliver because we have prevented it. And I think Colin makes a hugely important point about, of course, COVID is urgent, but the climate crisis is important, and never confuse the urgent with the important. And health professionals are very good at focusing on the urgent, the blue light, the drama, without necessarily seeing the important long-term consequences. So that is by far the most important thing. There are other things like we have to respond well to patients who are increasingly going to inquire about health effects. So we're not that well trained in responding to that. But I guess the third most important response to your question is healthcare businesses spend a lot of money, a hell of a lot of money, and we need to use that choice that we spend money. It doesn't matter whether we're buying pharmaceuticals or surgical instruments or buying food or buying energy. We need to do it well, we need to do it low carbon, we need to do it fairly, and we need to do it visibly. And that last point is important because we need to be an exemplar. We need to norm climate action amongst the rest of the population. Just like smoking, if doctors smoke, it invalidates the whole argument. If the health system is seen to act not in a low carbon way, how can we expect everybody else to do it? So we have to be very visible in what we do, having low carbon, lean pathways, preventative health care, much more care at home, reducing waste, reducing harm, and living out our mantra of doing no harm and practicing our duty of care, both to patients, to public, and to everything that makes health possible. And that is keeping the climate under control.
David, thanks. That's great. Just before we go to public questions, which I'm sure some will be on climate, I just want to ask you fairly concisely, lots of people out there say, well, what the hell can I do to cut a carbon footprint? What can individuals actually do you think? What would you advise them to cut their own carbon footprint?
Well, I'd suggest five things, not necessarily simple, but 5 things. First of all, try and measure it. It's not that difficult to measure. You can go, if you have access to the internet, measure what your footprint is. We have to become more literate. We have to understand our carbon footprint like we understand our salary. It's important to us and our children's health, so we have to measure it. The second, or the next 4 really, is one, we need to eat better, eat much better, as we've already heard. So if you're a red meat eater, move to white meat. If you're a white meat eater, move to vegetarian. If you're a vegetarian, move to vegan. So we don't all need to be eating cat food in a cave. We just need to be moving slightly down the scale so we have a low carbon. Third one is travel better, move better. Never in human history have we moved around the world so much without moving our bodies actively. So we active travel. Thirdly, spend. In fact, changing your bank. If you have a bank, changing your bank, changing your investment is hugely important. Those people who are relatively wealthy, and that probably includes many people on this call, change your bank and tell them why you're changing your bank. That's very important. And lastly, is join together with other people who are similarly concerned. That will have a huge effect on social networks, on solidarity, on reciprocity, on hope, what's called hope through action. Not hope through sitting in the corner biting your nails, but joining together. And that has a very positive effect on your health and the health of your community and the health of the future.
Thank you, Dave. We must get those 5 points written down on our website because they're very important. We must tweet them. But can I just come back very briefly to Marina? Marina, we saw COP26. There were positive things, but there were also some disappointments. What must we do in a nutshell in the next decade to really start to hit targets to try and keep below 1.5? Because a lot of scientists think that anything above that is really dangerous to the future for our children.
Absolutely. It's incompatible with a healthy future. It's absolutely incompatible with a healthy future for our children. So we need to demand our politicians, our governance, and we need to vote keeping that in mind, empowering them to take that decisions and to fight pretty big powers that are keeping us from progress, to fight the whole political push and pull that they have behind softening the language and not including certain words in the Paris Agreement. This was the first time that a COP includes even mention of a fossil fuel, which is outrageous. We hadn't mentioned fossil fuels in our COP agreements before. It's like wanting to talk about lung cancer and not mentioning air pollution or cigarette smoking. It's absolutely outrageous. So, and the reason why that happened is because politicians are being pulled and pushed with different interests. But their main interest is their voters. The main interest is their people that are the ones that put them in power. So we have to be absolutely explicit in demanding politicians that they have to decarbonize and commit to a low carbon future.
Thank you very much. And I see that there's a very recent report come out from world scientists saying, look, we're really off track and we need to pay huge attention to the energy transition to economic reforms that correct all these market failures from pollution, to food systems to transit from a high impact to low impact foods, and above all, atmospheric pollutant reductions and protection of nature, and what's being called land health. But let's come on. I think I'm going to go back to our TV Deanan, Professor Deanan Pillay, our moderator, who's going to invite questions from the public. Deanan.
Thanks, Anthony, and I must say, Marina and David, thank you very much, and Anthony for coordinating that. And of course, Anthony, our very own Anthony Costello, was very much a key player in that Lancet report. So thank you very much. Right, so we move on to questions, most of which are around climate, and I invite our guests to just put your hand up if you want to answer those questions, and to remind all the panel, we all like talking a lot, but let's try and keep our answers succinct so we can get through as many questions as we can. So we start with a question from the press. Zoe Tidman, you're here, but I understand your microphone is not working, but if you would put your camera on, and then I can, I can pretend to be you in answering the question, in asking the question. If you can't, well, it's Zoe Tidman from The Independent. And with so many children with COVID, are you worried? Are you worried about the long-term consequences? And is there complacency around children catching COVID? So this question has been dealt with a number of times by us, but could you, who would like to sort of take a stab at that, given the ongoing high rates that Colin identified in his great presentation of the data earlier? Who wants to take a stab at that? Okay, Helen, and then Danny. Helen,
hello. Yes, I am concerned about the high number of children who've got COVID. I'm concerned that quite a lot of them are being ill, which is really unpleasant for them, and missing school, which is bad for them. I'm concerned that they're passing it to their families, and some of their families may be much more ill, which is horrible. And there are some kids who sadly get very ill and need to go to hospital. I think we're not hearing very much about child hospitalizations, but I think there's something around 100 a month last time I looked. So children do get ill from COVID. What we don't know enough about is the long-term effects of COVID. And there's been much made of by people who are worried about vaccines of, well, we don't know enough about the long-term effects of these vaccines. But actually, we know quite a lot about the vaccines. We really don't know quite enough about the long-term effects of COVID, how many of these children may go on to have fatigue that's long lasting, to have features of long COVID. So I'm really concerned that we seem to have accepted, or widely there seems to be acceptance, that it doesn't really matter so much if children get COVID. At least that seems to be the implication of making people go back into schools with no COVID mitigations. That there's an implication that it really isn't that important. And I think it is important. And as we've seen from the figures that Colin showed us earlier, it's also really important in terms of trying to get a lid onto this pandemic, because if children have it, everybody else gets it too.
Thank you very much, Helen. Danny Altman.
Yeah, just to follow up really briefly on the points that Helen made. So yes, a really serious source of infection, but to follow up on the long COVID point, it really is a thing and a common thing, and anybody who's worried about it should have a look at the long COVID kids leaflet that was put out the day before yesterday, and is it's available at for a Google search, and it's a very large number of children in this country who now have these long COVID manifestations, and even if it was only in inverted commas as bad as a serious glandular fever, that's a really big impact on their education, their social life, their family life, and just getting through education this school year. So really, not to be toyed with and not to be blasé about.
Thanks a lot. There's two hands up. Because we've got a number of questions on climate that I want to sort of maximize the time. I hope my colleagues are happy that we move on, Steve and Zubaida. So the next question is from Peter Hebard. Would you be able to sort of turn yourself on, as it were, and ask your question?
Can you see me? Yes. Just first to quickly introduce myself, I'm chair of the Engineers COVID Task Force, but I'm a fellow of the IMechE. We have members all across the world, in the Far East particularly, who've been very helpful on COVID, but we've also got members, an association with ASHRAE, who are the ventilation experts in the United States, as well as our own members. So I've been looking throughout COP26. We had our own conference pre-COP26 at solutions for that, but because I'm focused also on COVID, I was looking at the solutions, well, the conflicts and the common solutions. What is very evident on both of them is how do we actually foster a better collaboration between scientists and engineers, academics and practitioners. What's common to both these problems has been a huge focus on investigating the problem, but very much less effort focused on looking at actually not the major single bullets like vaccines and electric cars, but actually the low-hanging fruit, as some people call it, that might make a big impact both on the infection spread in terms of COVID and in terms of that short-term reduction in the next 5 years. Electric cars will push it up, not down in the next 5 years. So, as I say, what has been very clear is that we haven't been really looking at the lower cost, least damaging solutions. To give you the one that probably is worth using as an example, ventilation, you might say the conflict, particularly in hospitals and schools, is fine to open the windows in summer, but in the winter, that creates problems. However, if you go to, for instance, Scandinavia, one of the things they've been doing for years in schools is they've introduced heat recovery units, which actually introduce fresh air, but in exhausting the stale air, they take the heat from it. Now that gives you a flow of clean, warm air, which you can actually use to as forced ventilation. And in fact, there is, looking at where it's been done before, aircraft were modified after SARS, and they've modified the flow of air from back to front of the aircraft to top to bottom. In other words, those vents above you were used to force clean air over your face, and then it goes out below your seat.
So, Peter, sorry to interrupt. So the question really is around how can we work together?
Exactly. We need to foster that collaboration. And okay. Over to you.
Thank you very much. David?
Yeah, thanks. Thanks, Peter. I mean, just in terms of trying to tease out the important question from your very valid comments, as Dean says, getting people to collaborate, and we've had to do a lot of this across the health service, because the health service is not one unified, there are a lot of tribes within the health service. I think the bottom line for me is helping people listen sympathetically to other people people and not getting into this terrible situation of my solution is more important than your solution. I mean, when people get passionate, and rightly passionate, about an issue like climate change or COVID, one naturally becomes quite single-minded about one's own experience. And I think you're right, it's very difficult to just keep your mouth shut and listen to where the other solutions are coming from. And I think one comment that I've experienced is that a lot of solutions, both to COVID and climate, are coming from the least privileged places in the world, which are under the most stress. And I think it well behooves those so-called industrialized developed countries to listen and look and think very carefully about some of the solutions that are coming from some of the less privileged and wealthy parts of the world. And that especially applies to how to live a low carbon life. In fact, go all the way back to indigenous people. I mean, I'm working with groups of indigenous people, first country people in Australia, where so many solutions are just sitting there. And here we are shouting about our own solutions when we're the biggest causes of the problem. So great that you've got some solutions in engineering, but I think the key to it is listening to other people and seeing how we can make one and one make three.
I would totally agree with that, but and particularly we should look at the Far East, where death rates were 4,000 times less in some countries. We need to learn from. There's a lot of focus on Europe, but there's an awful lot in places like Taiwan, Vietnam, where they've really got it under control much quicker.
Thank you, Peter, and exactly right. And thanks for underlining that international comparison. But we come back to the air quality issue, which, of course, as we've said for many sessions, has been undervalued by the by governments. So thanks for that discussion. The next question is coming from Vanessa, who has asked as follows. Are communities in the global south more exposed to health implications due to, as a consequence of climate change? And what are they? And then what policies need to be in place to address this issue? Now, a huge question. Some of this was touched on already by Marina. So is there anything, either Marina, David, Anthony, or any of the other panel, anything additional that is that you'd want to add as an answer to that question, the specific health implications as we stand of climate change?
I could just touch on that very briefly. Yes, the global south, and particularly when we talk about lower middle-income countries, they're definitely being more hard hit by the climate crisis. But that comes for two reasons. First, because many of the countries that are in the tropics, in the areas that are hotter, are more affected by extremes of heat and are also more affected by extreme weather events. Smaller and development states are also being affected disproportionately by rising sea levels and extreme weather events as well. But that doesn't mean that the higher income countries are untouched by this. And it's very important to note that it's the most vulnerable of every community, of every country, that is being disproportionately affected. We've seen this year the heat waves in Canada, in the US. We've seen the floods in Germany, very affluent countries with very strong healthcare systems, and still they do have very marginalized communities that were particularly suffering the health impacts of these extreme events. So while it's true that the global south, by and large, is more vulnerable, that is, again, underpinning the problem of inequities, it's also important to note that it's really affecting everywhere in every country of the world, and that inequities undermine the foundations of our good societies and the good functioning of our social systems.
Thanks, Marina. And Anthony, before we
just one very quick thing. The Prime Minister of Barbados, she gave a wonderful speech at COP26, and she said the financial institutions of the world and central banks have spent $25 trillion over the past decade on propping up the financial system and keeping stock markets going through quantitative easing and the like. Yet we promised in 2015 to spend 100 billion, which is a fraction of that total, annually to help the poorest countries and those that suffer loss and damage, like Barbados, like small island states. And even after COP26, 6 years later, we still haven't reached that level. And that was a scandal, really, coming out of COP26, that the wealthy countries of the world did not step up to really protect the poorest people who've contributed least to this problem. So I think this is a political issue, and people listening to this must be aware that it was the rich countries of the world that are failing on this. It's not to blame India or others like that. They have to play their part, but rich countries are letting others down.
Thanks, Anthony. And then, Colin, sorry, I missed your virtual hand. We've got used to the Luddites amongst us who have to put up our physical hands.
I just wanted to mention very briefly an interesting paper that came out in Nature this year called The Mortality Cost of Carbon, which for the first time allows us to link directly carbon dioxide emissions to the number of deaths resulting from those emissions. This paper was focused particularly on heat-related deaths, which, as Marina points out, does affect us in Europe. So in 2003, we had tens of thousands of people in Europe die due to the heat waves here. And so now you can start to do things like say, well, with the development in the North Sea that it looks like the UK government is preparing to approve, this new oil field at Cambo, that has 800 million barrels of oil. And so we can say, well, that should be associated with 80,000 deaths between now and the end of the century, just from heat-related causes. And I think it's important people think about that consequence and whether that's really what we want.
Thanks, thanks, Colin. Now we've got two more questions, but they sort of very similar, and they touch actually on something that Anthony has just said. So I'll read it out. This is from Jeremy, who's in the Philippines. India successfully watered down the decisions of COP26 because developing nations can't completely cut out fossil fuels. That being said, the developed nations pressurized developing countries to phase out coal haven't delivered the annual $200 billion promised in the Copenhagen COP 2009 to developing countries for climate change mitigation and adaptation. So if global health has to be improved by mitigating climate change, shouldn't developed nations be doing more financially? How can developed nations better finance global health response in developing and poorer nations? So it's a similar sort of question, but much more focused. Who wants to take this? Anthony, do you want to continue on your point? But this time unmuted, if possible.
Thank you, Dylan. Number one is subsidies. We are massively subsidizing fossil fuels still all around the world. So there's a negative carbon price. You know, the principle in economics is the polluter should pay. Every time you take a flight or a car journey, you are polluting the planet, and you should therefore pay a price to reflect that. And we don't do that right now. And it isn't that we just add on carbon taxes to our existing taxes. Let's scrap income taxes or slash them and put everything onto a carbon tax, which you tax at source at the oil companies and the like, and then you can you can give those bonuses back to people, and if they have a low carbon life, they're going to be richer. Now, you have to protect the poorest when you do that, but we haven't got to grips with removing subsidies, carbon prices, and shifting the way we tax people.
Thank you. And Tolu.
So I want to add to that and link to the earlier conversation around air quality, because in addition to what we're not doing, we also need to stop some of what we are doing. So the United Nations Environment Programme, UNEP, released a report last year looking at air pollution and export of cars, largely from Europe and United States, and found that, okay, so we know that a significant source of air pollution is transport and cars, and we know that it's a priority everywhere, including Europe, to clean up the global vehicle fleet. But the vast majority of those cars that are particularly polluting are ending up in the global south. So we're cleaning up our air by exporting our dirty cars to largely Africa. Actually, the west coast of Africa takes up a lot of that, as if we're not on the same climate. And so in addition to what we should be doing, what we shouldn't be doing is we should be pushing for global accountability as part of our local action to cleaning up air and move beyond just, the ultra low emission zone in London, etc. Great, we're doing that. We're cleaning up our air. Where are cars ending up? And I think we need to make that connection to ensure that we're not robbing Peter to pay Paul.
Thank you very much, Tolu. Marina, very quickly, because we're out of time, last comment from you.
I'll make a very, very brief comment, and it relates to international finance as well, and particularly to COVID recovery, because we're now about to commit trillions of dollars to COVID recovery plans, mainly in higher income countries. And we're at really high risk of those recovery plans fueling a carbon intensive economy. Up to halfway through last year, we only estimate that 18% of those recovery plans would have promoted reductions in CO2 emissions. So as we recover from COVID, trillions of dollars and rolled towards undermining Paris Agreement, and we're risking undermining Paris Agreement's goals. Whereas if we redirected them in line with Paris Agreement goals, it really dwarfs that 100 billion that we've been talking about before. So we're in a bit of a pivotal point and an opportunity there to align, not leaving the COVID crisis to enter the climate crisis for health, but actually driving both in the same direction to have a healthier lifestyle and future.
Thank you very much. So we've come to the end of our of this session. Thank you very much. First of all, Colin, thank you for your unique style of presentation of the data. Excellent. And also Marina and David for being here as experts together with Anthony, talking about a really important issue, which is of course climate and health, which impacts on how we respond to COVID in an ongoing way, as well as future pandemics. So we will, of course, be with you next week, as usual, this time, same as we say, same time, same place. Until then, stay safe and goodbye all.
Thank you. Bye-bye.
Bye.
Bye-bye. Thank you, Colin, David, Marina. That was excellent.